So good afternoon, everyone. Thank you very much for joining us on our last Global Health Seminar series on the theme of humanitarian health. So while we have more people continue to join the room, first I'd like to give a very good afternoon to everyone and thank you very much for joining. My name is Evelyn and I'm an associate consultant at the National Cancer Centre Singapore, as well as a clinical instructor with SDGHI under the Global Health Seminar series. So just some quick housekeeping before we start. You should be able to see a question and answer box on the Zoom bar. Please use that to let us know if you have any questions for our speakers today. We will hear from both speakers first, and then we might have some time at the end where we will try to answer as many of the questions from that particular Q&A boxes. So today we are running out our series of 3 webinars with not just one, but 2 speakers. And we will first hear from Professor Dr. Natasha Howard. So with a dual professorship here at NUS, as well as the London School of Hygiene and Tropical Medicine, Prof. Natasha is an interdisciplinary health policy and systems researcher focused on Asia. Her work is predominantly applied, drawing on theories and methodologies from epidemiology, political sciences, and sociology to improve health system responses for populations affected by protracted adversities, such as that of conflicts, displacement, and poverty. Her projects emphasize productive and capacity building international partnerships, team diversity, and interdisciplinarity, as well as inclusion of marginalized perspectives. So today, she will be sharing with us on the topic of how do we strengthen health system responses during protracted adversity. So over to you, Prof.
Thanks very much. Hello, everybody, and thanks for joining. Let me just share. All good?
All good. We can see it very clearly. Thank you.
Okay. So just to give a bit of a caveat first, this talk is looking at strengthening health system responses, but at the same time, because of the areas in which I will be talking about, I'm not going to focus so much on the system itself, but more at the frontline interface. So to give a bit of an overview of the kind of work I'm talking about, when we think of protracted adversity, there's no agreed definition on this, but you'll frequently see related terms when we're talking about like protracted crises, conflict-affected, structural violence, systemic inequalities, etc. And what makes it somewhat preferable to terms like fragile, impoverished, failed, is it's not assigning blame on those who are experiencing any type of adversity. So it's thus referring to these prolonged and persistent challenges that can impede group well-being across various dimensions: political, economic, social, or environmental. So as you can imagine, it's quite complex, many interconnected factors, conflict being one of them, displacement, forced migration, poverty, environmental degradation also, which exacerbate these vulnerabilities. The important issue to consider is that this goes beyond thinking of the health system in the abstract to really look at people's lived experiences and ways of supporting that, especially those potentially most affected. So think of these as kind of the most complex of the complex settings. For this talk, I'm going to focus on challenges in Syria, Afghanistan, and Nepal, resource scarcity, human resources, infrastructural damage that can affect both people's access to and use of services, and start thinking a little bit about some potential low-cost strategies for improving or aiding delivery. So my focus isn't so much on external humanitarian aid, because Dr. Zeena is going to be talking more about that. So this is a bit broader overview, just to kind of set scenes. So these examples, Syria has been affected by a over 10-year multi-party conflict. We can no longer properly call it a civil war. Healthcare has been fragmented, particularly across the different areas of military control. There's 3 primary ones. But previously, before the war, it was quite a decent health system. So our focus the research that we did was on frontline health system governance. So particularly frontline workers and how they were kind of gatekeepers for access and services usage. For Afghanistan, this is a truly protracted conflict, 30 plus years, a relative period of peace, ongoing subcontracted healthcare delivery, but now recontrolled by the Taliban, which has affected health services provision considerably. So we've done quite a lot of research, but now it's all a bit older. But the intention of that research was really to inform localized, individual, and family level personal protective interventions. And Nepal is a lower middle income country post-conflict. It had about a 10-year civil war and has a very devolved healthcare delivery structure that is quite recent. So that is still an ongoing issue for the country. And for Nepal, we were looking at community level understandings of anthropogenic and ecological drivers of zoonosis spillovers, potential spillovers, particularly from rodents, bats, and dogs. So as I said, pre-conflict, the health system in Syria had developed quite rapidly with declining mortality and infectious diseases rates and improved life expectancy at birth. There were, however, limited community services. The focus was primarily hospital-based, with government as main funder, very centralized. So there were ongoing challenges even before the conflict in terms of overall inequities, data validity, lack of transparency, etc. So our aim was to explore frontline health worker and service user experiences and how they were affected by the very fragmented nature of health system governance. We also looked at COVID response governance simply because the timing worked out quite well when we were looking at other issues. So we looked across all areas of control and also made sure that we focused on women health worker experiences as these had been underrepresented in previous research. So because of our emphasis on generating information in spaces that were actually quite difficult to access and inhabited by potentially very, very vulnerable people, we had to do this remotely, which is why COVID made no major difference in our research, mostly through WhatsApp interviews. And our findings were the obvious ones that the conflict led to severe deterioration of living conditions, health system erosion, ongoing attacks on healthcare, with vital infrastructure compromised, health workers killed or having to leave the country, breakdown in water, sanitation, food infrastructure. What we also found that was interesting with ramifications for humanitarian response and donors was the fact that donor funding tended to worsen rather than improve this fragmentation by the lack of a common funding approach, many different donors working in different areas, working on different topics, ongoing politicization of aid, and a lot of parallelism and working around existing governance structures such as the health directorates rather than trying to support them. So other findings were that accountability and complaint mechanisms did exist, but most service users preferred just going directly. They didn't make use of formal mechanisms. And transparency was very, very challenging, not really addressed properly in any of the governance areas. Rule of law was just, there was no real conceptualization of it all, which is quite understandable. Equity was also interpreted very, very differently by providers and service users, in terms of favoritism kind of being seen as a good approach by the one side and not so much by the other. But we did not find any sort of systemic discrimination. Health information was collected relatively effectively given the circumstances, but not routinely analyzed. And participation, say, of service users in different aspects was not done, but also wasn't particularly considered. So accountability is an unsurprisingly ongoing issue. Potential strategies that have been looked at to help support a very, very fragmented and damaged health system where it's not necessarily possible to get to health facilities or to get treatment in them, is strengthening community-based health workers who would only be able to deal with basic healthcare services, but still could provide that support within communities. And SAMS, an NGO that is working in Syria, has been working to support CHW delivered services in hard to reach areas particularly. Also telehealth, leveraging these types of technologies to provide remote consultations, advice, etc., both for service users and in terms of training up service providers. I think there's quite a lot of potential for this. It's being trialed a bit, but not very extensively as of yet, and probably has quite a lot of potential, quite a lot more than some of these others. Mobile outreach, pros and cons of this. It's one way, but it's not very sustainable. It tends to be quite expensive. But these are some issues to consider. Moving on to Afghanistan. Its health system has been challenged for decades, now particularly with the Taliban 2.0, for want of a better term, takeover, which has led to limited access to healthcare and ongoing uncertainty in terms of what is possible, what is not possible. So many facilities lack basic amenities, lack sufficient staffing, etc. Many staff have left. Some of the research that we have done, and this is going back 20 years or more, some of it, was looking at, particularly at vector-borne disease control. So this is malaria and leishmaniasis predominantly. Preventive activities with the assumption that you don't want people to have to need services because they might not be able to access them. So really focusing on indoor residual spraying and nets, etc. We also did some work looking at intermittent and presumptive treatment for malaria in pregnancy. And I'm not going to read the whole slide, it's quite dense, but you can have a look at it. For intermittent and presumptive treatment, the data were pretty clear that this was not a feasible solution, was not a good idea to pursue, given relative lack of interest among pregnant women, the fact that malaria prevalence was low enough that it just didn't make any sense. In terms of using indoor residual spraying, we had a data set over 10 years of looking at adding IRS to insecticide treated nets, and determined that it was very, very cost effective for Vivax and cost effective for falciparum. Just as a side, falciparum malaria rates in Afghanistan are quite low. It's 10 to 20% of overall malaria. CME is looking at community midwifery initiative. And one thing to note about the community midwifery initiative in Afghanistan is it was actually very, very good, very, very effective. A good case study for any region or country looking at ways of getting health workers within communities, because it was hiring women from communities, training them, and then having them work within their own communities. So it provided support for these women, trained them up to midwifery standards, not to auxiliary, not to skilled birth attendant, but proper midwife. So these were women who actually were properly licensed midwives, but working in communities. So it's a approach that has been tried in some other countries. We also did a publication on looking at some other countries that have tried this, but worked very, very well for these kinds of fragmented, challenged environments. So considering potential strategies in Afghanistan, community health councils, along the same idea of village health committees, community midwifery education, training, deploying, and supporting, and ongoing health education campaigns. Of these three, I would say that the CME is the most useful approach that we came across. Briefly looking at Nepal, given I have relatively little time left, the key elements of the system is the Ministry of Health and Population is responsible for formulation and planning and organization coordination. But the health system is generally quite devolved, as I said, to the regions. It has a large rural population with minimum access to healthcare. So again, when we're talking about systems, we're trying to look at ways of improving prevention kind of pre-health facility, so that there will be less of a burden on health systems that are already extremely challenged. We focused on zoonotic diseases because this is considered a growing issue in Nepal. Our initial findings were taken from key informant interviews with professionals, government, and community representatives across the country, noting that this landscape is very complex with competing priorities and funding limitations and competing policy attention for many, many other issues. A very diverse range of actors, but overall, a general support for a stronger One Health approach. In communities, people were well aware of zoonotic risks. It wasn't so much an issue of lack of awareness. Always the first thing people want to do is increase awareness, have campaigns. But it was much more about having to make pragmatic decisions. You know, if I take a risk, but I need to feed my family, I will take that risk. So awareness would not help me, for example. So overall, the consideration was ways of strengthening a One Health approach to be a more integrated way of dealing with infectious diseases. Other issues to consider: community health volunteers, again, CHWs, CHVs, the same type of approaches. As you'll see, there's kind of commonality across these three locations. But also thinking very much about task shifting and expanding the role of lower and mid-level health workers to be able to provide additional areas of care so as to not overburden specialist care. So in summary, as I'm wrapping up, support and early recovery in these environments, both conflict affected and lower income countries, a lot of things look quite similar, but there is regularly a reliance on external funding and training and capacity building, et cetera, to strengthen service delivery and health system governance. And the problem with this is that internationally, we all also know that there are always competing priorities and new interesting things that distract attention from ongoing protracted crises. So the amount and length of support is primarily dependent on external donor priorities rather than need or any other measure. So the takeaway from this is research is possible, but it needs to be very much bespoke and appropriate to these environments, because a lot of relatively rubbish research can get done simply because it's easier, as opposed to what is actually useful to inform policy and practice. So the intention should always be, where resources are extremely constrained, to very, very much think about, okay, what can be done that will add value rather than just distract. So in each of these contexts, community engagement, capacity building, and adaptable approaches are crucial. And each of these examples demonstrate the importance of being locally contextualized, leveraging local resources and interests, empowering local actors, including community actors, and choosing context relevant interventions, whether for piloting or for evaluation. So lessons can be learned to inform future areas of work in countries that are facing similar challenges, and to contribute to more responsive health systems for these countries. Thank you very much. Over to you.
Thank you very much, Prof. Oh, so there are a lot of questions that I had in my brain as I was just listening to your talk, and we'll probably put that to the end, because I think I'm gonna wait for more questions to come in as well. But I think it was a very good topic that you actually gave a very good overview on how it's necessary to do proper needs assessment in order to actually, come out with interventions for each of the countries that's specific to the country and depending on the players that's actually involved in the country as well. Without any further ado, I do want to introduce Dr. Zeena, but once again, to the rest of the participants in the talk, do feel free to actually just put your questions on the Q&A, and we will definitely try to answer as many of them as possible. So now we'll move on to Dr. Zeena. So Dr. Zeena is actually a senior resident from the Preventive Medicine Residency, specializing in occupational medicine. Before I actually introduce her, I'm really happy that she's actually wearing her NUH scrub, because I kind of just want to emphasize here that, in this community, it's really just about, bringing together everybody from the different aspects of Singapore who's actually doing global health work and coming together on a certain platform to actually discuss about the things that we're doing, because it's a small community and we should support one another. But yes, anyway, so yes, she graduated from Imperial College London with both an MBBS degree as well as a BSc in global health. She additionally holds a Master of Public Health from NUS, and with a passion for global health, she has been involved in various projects aiming at improving healthcare access for vulnerable populations. In July 2023, she volunteered in Athens, providing primary and urgent care to refugees. And she'll be sharing some of the experience with us today in her segment entitled Refugee Health Insights from the Field. So Dr. Zeena, please inspire all of us.
Thank you for the great introduction, Dr. Evelyn. Let me just share my screen. All right, okay, give me a second. Okay, perfect. So thank you so much. So I'm Zeena. I'm one of the senior residents from the Preventive Medicine residency. And last year I took a break from residency to volunteer with a medical NGO in Athens. And so today I'll be sharing my experience with you. So since we're on the topic of refugees and migration, I thought it would be apt for us to cross the 7 seas today during the sharing. And the 7 Cs are this. So we'll start off by talking a little bit about the refugee crisis or the situation in Europe. And then I'll move on to give you a little bit of context, so explaining to you about the NGO that I was working with, and then sharing with you about the care that we provided for the refugees. I'll move on to talk a little bit about the perspectives and experiences that I had gained, and then end off with some challenges that I faced and some lessons that I've learned. And I'm happy to answer any questions after. So before talking about the refugee situation in Europe, I think it's very important to orientate ourselves geographically. So this is where Greece is, as highlighted here. Turkey is very close to Greece, and it's separated by the Mediterranean Sea. We can see the sub-Saharan African region and the Middle East, and Greece is often touted to be the gateway to Europe. So I'm not going to go into a lot of detail talking about the legal framework surrounding asylum seekers and refugees in Europe. But I think there are key important events to highlight. And one of those is actually the EU-Turkey deal, which was struck in 2016. And this was one of the EU's response to refugees, because in 2015, almost about 1 million refugees ended up in European shores, and 75% of those were fleeing persecution and conflict in countries such as Iraq, Afghanistan, and Syria. So this deal was struck basically to help manage the situation. And the first thing about the deal was that whoever refugees who actually ended up in the Greek islands, so Lesbos, Samos, Leros, Kos, these had refugee camps. If they are deemed to be inadmissible, they will be returned back to Turkey. So if they are refugees coming from Turkey to Greek islands with aspirations to move on further into Europe, but if they're deemed inadmissible, they will be returned back to Turkey. And what does it mean to be inadmissible? It does not mean that you're not eligible to seek asylum, or it does not mean that you cannot be a refugee. It just means that the authorities feel that Turkey would be a safer country for you. And we are not very sure as to how this is deemed, how the authorities actually deem that Turkey is a safer country. And in return, of course, Turkey gets funding. There were talks on visa requirements being removed for Turkish citizens who are traveling in EU member states. And in 2021, there was a joint ministerial decision that was made where 5 nationalities, so refugees coming from not only Syria, but also Afghanistan, Bangladesh, Pakistan, and Somalia, that were coming into Greece, they were actually automatically deemed inadmissible, and authorities automatically would deem Turkey as a safe country for them. So this would mean that their application will not even be processed. So they'll be sent back unless they can prove that Turkey is not a safe country for them. And from speaking to people on the ground, it's very hard to actually prove that Turkey is not a safe country. So most of the time, they are just deemed inadmissible. And we'll talk about the repercussions of that a bit later. And of course, at this point, we have to mention that, we've only been talking about people who did arrive on the shores safely, but there are a lot of people who actually take on a harrowing and treacherous journey, which saying that in itself is an understatement, but they oftentimes do not even make it to the shores safely. So with that context, we can actually understand the crisis even better, because a lot of the times the refugees who are deemed inadmissible, meaning to say that their asylum applications are not even processed, are sometimes when they're sent back to Turkey or they are given the instruction to go back to Turkey, Turkey will not accept them. And during the pandemic, this is when we saw Turkey actually did not accept any of the returnees back. So there was this thing called a legal limbo where they're not allowed to have asylum in Greece, and they were not accepted back into Turkey. And because of that, they had no legal status, no refugee status, no access to basic rights, so housing, healthcare, or safety. And a lot of them were actually staying put in the camps because they can't move anywhere. So there was a lot of overcrowding in camps. And as you can imagine, this would just lead to poor living conditions and will bring on a lot of medical conditions and challenges in itself. And at one point in time, a very prominent camp in Lesbos, one of the Greek Aegean islands, which had a capacity of approximately 3,000 refugees, was actually housing about 24,000 refugees. So you can just imagine the crowding and all the public health problems that had arisen due to that. And for those who actually get legal access and legal status and have access to healthcare, the Greek healthcare system is not the easiest healthcare system to navigate. It's very complex, and compounded with that is actually the language barrier, because a lot of them obviously do not speak Greek. And so this is where the NGOs then step in to kind of close the gap, and this is where we have a role to play. So the NGO that I volunteered with is a German NGO. It's called Medical Volunteers International. And at that time when I went there, they had projects in Greece, Serbia, and Bulgaria. And their main mandate was to provide primary and urgent healthcare to refugees and people on the move. So in July 2023, I was posted to Athens for a period of about 10 to 10 and a half weeks, where I worked with volunteers all over the world to provide primary care. So my daily work as an MVI volunteer in Athens, we had a lot of different clinics and activities, and we were rostered. So one of the things that we did is doing medical outreach for people living on the street. So these are people who either do not want to seek healthcare facilities because of fear of getting caught, or they do not have papers. So they are living on the street, and most of them do have a lot of wounds. Because of the poor living conditions. So we have to go to them to actually provide wound care. And as you can imagine, it's quite challenging because it's a very, very challenging setting, right? You're providing wound care the side of the road, basically. So a lot of the times you need to practice your clinical acumen, you need to triage appropriately, you need to look at a wound and say, okay, this patient really needs to go to the hospital, he needs IV antibiotics, or okay, this patient, maybe we can handle with oral antibiotics. And you also need to make decisions as to whether this is exudative, you need to use a hydrocolloid, you need to use a paraffin. So all of this, you need to make these decisions in the roads, in the streets, and it's very difficult because there are a lot of people around, there are a lot of drug abuse that is going on around as well. So you need to be very alert, but at the same time, we were actually collaborating with another NGO, so they would always be around us, and they spoke Greek as well. So that's one of the things that we did. We also worked with other NGOs that were set up in Athens. So these are NGOs that are specifically caring for specific sections of the population. So for example, One Heart is a charity that provides care for Farsi-speaking population. So people from Afghanistan or Iran. So we used to go to their clinic to run their clinics for them. Seeds is a Palestinian charity which provides care for Arabic-speaking patients. So sometimes we do refer our patients to them because they are Arabic translators, so Arabic patients can be seen there. We did work in refugee camps as well. And I'll explain about that in a bit more detail. And we worked in our own MVI clinics in the city center in Athens. So this is me and one of my German colleagues. And the good thing about MVI is that you run clinics as two people. So consultations can be very, very long because you're not only dealing with their physical ailments, you're also dealing with their social situation. You're looking at their safety, emotional health, mental health. And on top of that, we have a language barrier, so we have a translator. So consultations can be very long. So having two people will help with a lot of the decision fatigue, because then we can run through the cases and the plans together and come up with a management plan that's comprehensive. So just to talk to you a little bit about Greek asylum seeker card. So this is an example of a Greek asylum seeker card. And this is actually very important for us in our management. So what we do when we see a patient is actually take the card and we type it in a Greek portal. We put in all the details like mother's name, surname, father's name, the paper number. And what we're trying to find out is whether the paper or their temporary social registration number is valid. If a patient's paper is valid, this means that I can refer them to a Greek healthcare system. If it's not valid, then I can't refer them to a Greek healthcare system. And that's when I tend to look at other NGOs like MSF or Médecins du Monde, Doctors of the World, where they have chronic care management or other specialist care that's provided. There is a case of a patient that I saw with really, really bad fibroids. She had tummy distension and it was obstructing all the surrounding structures. She was having urinary retention, swelling of the legs, and she really needed to have a gynecological evaluation. So in this case, we have to refer her to a Greek healthcare system. And so what we did was we referred her, and an NGO would actually go down to advocate for her. And such cases have happened. So medical passport is also another important thing. So this is an example of it. We do write down our consultation and what the care the patient has received, so that when refugees do move on to other parts of within Greece or to other parts in Europe, they have the medical passport with them. And this is a small way that we help with the continuity of care, especially because of language barrier itself. So just to share with you about my experience working in refugee camps. So this is how the camps look like. And at first glance, you can see it kind of gives off prison vibes. They are on camera surveillance all the time. The gates are locked. And they have 8 a.m. exit, 8 p.m. They can only enter and exit from 8 a.m. to 8 p.m. So beyond that, they cannot leave. And they always have to sign in before they leave and stuff like that. So it gives off a real carceral feeling. And these are kind of pictures that I took of, you can really sense the desperation. They just want the walls to go off. They just want freedom, especially because they flee conflict and persecution only to be caged up here. So when we actually tend to go there, we spread the news that we are there through word of mouth. And 2 of our MBI translators have friends in the camp. So actually word of mouth is very powerful, because in a 2-hour session, we can see up to about 30 patients lining up for us. So a lot of demand is here. So we actually provided care for 2 refugee camps. In Corinthos, we actually worked with another NGO, so they actually rented out a clinic space for us. The downside to Corinthos is that the refugees have to walk about 20 to 30 minutes to reach us, whereas here we're just outside the refugee camp. We drive there and then we literally set up a tent. It's like a mobile clinic, and we have the outreach bags with us. The van actually serves as a kind of like isolation. So nurses will try and get their details and do all the necessary triage, and then they come behind the van and see the doctor for a little bit of privacy. It's not the most ideal or optimal setting, but it's what we have with our limited resources. So just to give you a brief a look of some of the patients that we see. So we see a lot of dermatological conditions, especially during the time that I was there, which is the heat wave in Athens. So a lot of heat rash, a lot of nappy rash, especially bedbugs and scabies. So as you can probably imagine, the refugee camps, living conditions can be quite poor and hygiene might not be great. So a lot of the times we try and coordinate with the other NGOs and camps to say that, hey, there's a case of scabies, can you please have a look? But sometimes, that does not really translate to anything useful. So in this case, we need to empower the patient. So we actually explain to them about the condition and how to check for bed bugs and stuff like that. We also see a lot of mental health conditions, so PTSD, acute stress disorders, which sometimes can present as somatic symptoms, right? They're coming to us for headache, back pain, and so it's important that we tease out to see whether there's any underlying mental health condition that we need to, ensure that we deal with. At a point in time when I was volunteering there, MVI did not have any psychological services. So we always have to refer out to NGOs like MSF. But then after that, I think they realized that there was a demand. So they started to bring out, so now they do have a psychological service, a psychologist who are volunteering with them. I just wanted to highlight about this case, the 6-year-old with severe strep tonsils that we saw. So when we saw the patient, actually, the boy was so apathetic. He was usually quite energetic. He didn't want to play with us. Very high respiratory rate, high fever, high heart rate. Didn't want to eat. Mom said he wasn't eating, very dry mucous membrane. So when we look at the patient, we said, okay, this one really needs to go to hospital because he can turn into something bad immediately. So we kind of spoke to the mom. The mom didn't have any papers. So we said, okay, we'll advocate for you. We'll go down with you. But she had 4 other children and she was alone. Her husband had passed on. So she was like, there's no way I'm actually going to A&E with 4 other children. So then we had to think on the spot. So one of my colleagues very innovatively thought, okay, you know what, we'll try and observe him. So we gave him paracetamol and then we kind of engaged him. Slowly he was okay. Then we tried to examine him. He had very bad strep throat, but thankfully no quinsy. So we treated him with Augmentin and Pred, observed him some more. And then when he got a little bit better, red flags, we advised them red flags and then asked him to come back early next morning for a review. And thank God he got better. Just to highlight that there's a lot of barriers. It's not only structural or legal. Sometimes it can be cultural, psychological, familial. And it's important when we are there with our limited settings, we kind of think innovatively, which is what my colleague did. Instead of being like, okay, this patient has to be seen in ER, you just have to really try and adapt to the situation. I just wanted to quickly highlight some of the things that I thought of, like in terms of, looking at the big picture and public health. I think the biggest thing that kind of creeps up on you when you're working in an NGO is kind of like the role of other NGOs and the role of your NGO. Is it unity in diversity, or are you providing fragmented care? And the reason why I say that is there's so many NGOs. And as you probably have ascertained from the sharing, there's a lot of collaborative efforts, but these are all informal collaborations. There's no structured, coordinated response, right? A lot of overlapping services. Everyone is siloed in their own NGOs. So it can actually confuse a lot of patients. So that's just a food for thought now. And also, ensuring there is a demand versus supply. In Athens itself, there's more than 10 NGOs, but then obviously refugee camps they have a lot of demand. So kind of ensuring there's some sort of resource prioritization. And again, going back to Prof. Howard's point of view of needs assessment. Of course, continuity of care is always in the back of our heads when we are going down for any kind of humanitarian efforts. Is the turnover of volunteers, and it's definitely number one. And also speaking of refugee contexts, they do migrate to other countries. So how do we then ensure that they continue our care? Our medical passport is just one way to combat that. So in terms of challenges faced, I just separated them into physician and personal challenges. So of course, from a physician's point of view, coming from a very well-resourced country like Singapore, practicing medicine in a resource-poor setting is very, very difficult, especially because you don't have all these investigations to fall back on. Your clinical acumen and your gut instinct is very important. When you hear crackles, when you think it's pneumonia, you treat it as pneumonia first. You don't have a chest X-ray. So these kind of things are very can be quite challenging, especially if you are very reliant on investigations. So this is a picture of my colleague and I trying to read the pelvic X-ray. A patient came in with a pelvic X-ray film and he didn't know what to do. And this is one of the cases where you refer a patient out to a GP, but it's so complex and they don't understand what's going on that they come back to us to actually gain more clarity. So then there's another colleague of ours who's shining an iPhone torch and we're trying to read an X-ray. So these are all the innovative types that we need to come up with in order to practice medicine there. Language barrier is another thing. I mean, we had really amazing translators, but there were times when there were no translators and we had to rely on Google Translate. And Google Translate sometimes fails us because there's no network, especially in refugee camps. So then we had to really innovate and stuff. Call Red Cross helpline. So there's a lot of issues, but I think the pro tip that I can give you for anyone who's going to humanitarian setting and work in other countries is learn a little bit of French, learn a little bit of Arabic, a little bit can go a long way because it helps you build the rapport and people really appreciate that you're trying to help with them. Another personal challenge that I need to highlight is the balance between being too emotionally involved and apathy. I think you can't help but be emotionally involved and very vested emotionally when you hear the stories that some of these patients go through. And it's important that you tell them that they are visible, you can see them, you're here for them, and you can hear them and you can listen to them. And that's very, very important. But at the same time, it's important that you don't feel so detached and you don't become too apathetic. Because I don't think it does anyone any good to be too apathetic, because their stories need to be heard and the emotions that you feel need to be felt. So that's very important to strike the balance lah. I think with really good support, I tried to overcome with time these challenges. And I was very, very grateful to meet a lot of people, from physicians, physiotherapists, nurses, human rights lawyers, and learn from them and be inspired from them, from their stories. Just 4 very exciting lessons that I've learned, and maybe tips I can give people who are interested in doing these kind of missions, is to be very humble, listen and constantly learn. There are things that you may not know. So for example, ultrasound was not even my forte, but German physicians are very good at it. So when you don't know and you ask them, they're very willing to teach you. Go with an open mind, so things can change very quickly. Don't stick to the JD that they give you and say, hey, this is not part of my JD, I'm not going to do this, because things change all the time. And you may be expected to do something that was not in your job description. So 2 weeks before my departure, that's when I was told that I was going to Athens. Before this, I was actually deployed to Thessaloniki. So things can change very quickly. Just be with an open mind and just accept everything and be prepared. Always have support systems. So we're very lucky because my volunteers, we all live together. So 8 of us living in a flat. So that means that we came back and we had people to talk to, and that really helped with our emotions as well. And yeah, so that's great. So having a support system is very, very important. So that's the end of my presentation. I'm happy to answer any questions.
Thanks so much, Zeena, for that very, 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 very inspiring talk. And I think I say this on behalf of everyone that's here, or probably even at least on behalf of my team, that I think what you've shown us in some of the examples that you do is kind of what all of us to a certain extent want to do without the kids and the husbands back in Singapore. I think I'll just say it for that. Okay, anyway. That having said, let's move on to question and answer. And I think there's quite a lot of questions coming in, and maybe we'll take the big picture approach first, and then we'll narrow it down to small questions. I'll just start on the very first question. I think somebody had asked a question about talking about the needs analysis of countries. Okay, so we all know that we go to different countries, that there's going to be different needs and in terms of capacity building. And I think someone asked a question about, what do you think are some of the things that we should actually go there to kind of like build up the capacity? Like, is it the basic skill trainings like the first aid, CPR, or perhaps should we go for a higher level sort of skill sets, depending on what's necessary? And I think this is just mainly talking about what do you think are actually some of the healthcare capacity building opportunities in these countries that you've mentioned, or in general any LMICs. Prof, would you like to take that question first?
I was reading the question in here, so what was your question again? I'm so sorry.
No worries. Actually, it was just a very short question. Like, what do you think are some of the sort of services that some of these countries are actually lacking in, and therefore would there be any value to things like first aid of CPR teaching that, in terms of capacity building that could help that? Or do you think that it's more like you really have to understand the needs analysis of the countries first before you actually can determine whether or not they will actually help?
I would say, you can make sort of general assumptions of what you expect might be issues, but it's always important to start with at least a basic needs assessment analysis, because with the best intentions in the world, you often get, okay, there's a earthquake or some kind of crisis, and everybody sends all sorts of stuff that they think is useful that then, has to be disposed of because it's not, or sending specialists in a topic that isn't directly relevant just because they're available, things like that. And it ends up causing more problems than help. So I think rather than assuming, it is important to, if you want to be trained in something, train yourself in needs assessment or get trained in needs assessment and start with that. UN agencies through the cluster system have comprehensive needs assessment structures. So you would expect that would be being done anyway. It's not as if every NGO or every agency has to do that independently. So it's more trying to be as collaborative as is possible in a very, very fragmented environment, as Dr. Zeena also alluded to make sure not to worsen that fragmentation, not to worsen that parallelism, and making sure that what you can contribute is also useful.
Great, and I think that actually goes in time with the question that's also Prof is just about to answer, which is that how does the data actually show the effectiveness and the impacts of some of these efforts? And maybe Prof, you could actually just answer that question live so everybody could also benefit from that.
This is a really nice question. Sorry, I noticed it too late to type and then I got distracted by it. My apologies. So the norm has tended to be, humanitarian actors coming in saying this is an emergency, therefore we don't evaluate necessarily, and that has been problematic, and one of the reasons why I was working in Afghanistan in the first place so many years ago was really kind of saying, okay, we know that it's a crisis setting, but at the same time we need to find out what works, what doesn't work. So trying to think, because humanitarian actors very much focus on immediate life saving, whereas development actors focus on sustainable initiatives. But there was, for a very long time, a huge gap between the two. One would leave before the next would start working in a setting. And this is why protracted settings are particularly interesting, because money leaves, people leave, problems continue. So the answer to what do the data show is there may not be data to show anything. Like often it doesn't get collected, which again, as researchers, as people trying to look at improving, that's a problem, right? If you don't collect the data, how can it be analyzed later even? So in these studies we actually did look at this and made sure to include it in terms of saying, okay, this is effective, but people don't like it. What good is that, right? So including in our efforts to analyze effectiveness. And a lot of what we were doing was classified as operational research. So not necessarily, exciting for academics who like to see, research council research, but very, very useful for practitioners. So if families, communities, other stakeholders didn't want to use something that we thought worked great, what good is it? No good. So the initiative, as I was saying, I kept going on about community midwifery. I would say that was the most effective. What I would say is the most useless, though people like to say it's really great because it's cheaper, is awareness raising. Most people are not stupid. They already are aware. They just can't do things about it. So what good is it to raise awareness without having an intervention that can then resolve the issue that you've raised awareness about?
Yeah, and sorry to interrupt. I actually just wanted to ask, like, do you think that all these social changes and implementation that you do on the ground, do you think that, and I speak this for some of the people that actually asked the question prior to the whole talk, do you actually think of the research topic first, then implement? Or do you actually implement these things first and then come out with the, what are some of the data that I should be collecting, and therefore these are the, sort of the endpoints that I should be looking at? Because I imagine a lot of the things on the ground, you probably think about, what action to be done first before you can actually know what kind of data you can collect. But I mean, do share your experience with that.
Honestly, it happens both ways. It can happen because a researcher has interest, hopefully through an evidence-informed, look at the literature, what's out there, and then having an idea rather than just, oh, wouldn't it be so cool to do X? Hopefully. And often it's donors who say, oh, we really want to look at Y. Go look at it. We'll pay you this amount of money. Less frequently does it come from any sort of co-development or community engagement. However, again, with various initiatives to be more decolonization focused within the global health space, there is more of there is more discussion and consideration, and to some extent efforts to try and redress this and be more community engagement focused and more collaborative, simply because we know the other approach doesn't work. We know that, but it still continues because it's still seen as easier. Whereas it's not easy if you spend lots of money and then nothing changes because you spent lots of money on the wrong thing. So ideally, we are shifting to something that is much more driven by affected people, but we're not there yet.
Okay. And now moving to Zeena, I think one of the questions that a lot of people are asking are basically on the ground, right? What are the kind of supports that you've been doing? And I think maybe we can share in two different angles. I mean, first angle would be, I think people wanted to hear who are the other volunteers are, what background they're from, and so on and so forth. But I think there's a second, there's also a question behind that, which is that if you're not a physician, can you volunteer? And what are the skills that you can also bring in to that? And I think one more question, which I think can also tie in very nicely, is that I can imagine that when you're working in a system like Singapore, like what you said, we have spoon-fed a lot of things. You can train FBCs for, every single day if you want to. But this is not going to be done, especially in, LMIC or in a refugee setting or in a setting that you were experiencing yourself. Coming back after spending one entire year or 6 months there, what are some of the things that you feel? I mean, I can imagine it's a completely different thing. And would you actually recommend our junior doctors to go out to actually explore these sort of settings before coming back, even as part of residency? Okay, I'll leave it to it.
Okay, so maybe answering the first question, who are the other volunteers? I actually worked with physiotherapists. I worked with nurses. We also had 2 field and medical coordinators who are basically coordinating the programs that the NGO would do on the ground. And medical coordinators are basically people who take stock, make sure that the medications are up to date. They will answer any questions in terms of referrals. They are the ones coordinating the referrals. So the question as to if you're a non-physician, can you still work in a humanitarian setting? Definitely yes, especially if you're allied health. There's a lot of demand for you. A lot of our patients we referred to our physiotherapy colleagues. Nurses, definitely yes, especially because we did a lot of wound care. So nurses were very, very, very really a vital team player in our NGO. From public health, because I do preventive medicine and I've seen the work that my co-residents doing public health are capable of, I actually see a lot of value add for administrators, because a lot of coordination has to be had. So you need to have the big thinking, the macro perspective, right? You need to make sure that you are doing needs assessment, making sure that your resource prioritization is actually practical and it can be implemented, and you're doing stakeholder engagement, you're doing networking, and these are all skills that as PH and administrators you'll be very, very good at. So there's definitely a value for you lah. So I think that I've answered those 2 questions. Maybe the last question is when I came back. I think personally, speaking to all my friends, I told them that actually it's a very, very good experience, especially as a resident or a junior doctor, because it really trains your clinical acumen. You really have to rely on your clinical skills to make decisions, be very innovative, not rely on investigations a bit too much. So it trains you in that. Also hones your history-taking skills, your patient-centeredness in your whole clinical skills lah. I think that's very, very important. And I see a value in that lah. Personally, I might be biased, but I do see a value in that. And I think I'm a better clinician coming back because of the experiences that I've had in Greece.
And do you think that there are any, I mean, just saying, would you think that actually you would encourage the junior doctors to actually experience, life outside the very sort of equipped hospitals like, like the ones that we have, really just to see what it's like, sometimes without being exposed to all these different things in different countries, sometimes we don't really know how good our system is actually.
Definitely, definitely. I think also you come back being a bit more grateful and a bit more feeling a bit more grateful and blessed, and a bit more like, I think you tend to complain a bit less. And also you'll see ways to improve the system here, I feel, because you are there, you're constantly looking for gaps, you're constantly innovating, that kind of trains your outlook as well. So when you come back, you bring that same kind of outlook here. And yeah, you're constantly innovating, which is great, right? Which is great in our setting as well, because there are things that can be improved. You gain that kind of perspective as well. I mean, I personally feel it's a great experience.
Okay, so I'm also mindful that we are reaching time, but before I actually go, I do realize that there's actually quite a lot of people in this call who are not just, I mean, we looked through the people who registered for the talk as well, and they're not just senior doctors, but there's also a lot of junior doctors. A lot of people who I know personally, and some of them are actually looking towards wanting to do research and field work, or are doing, and like what Dr. Zeena is doing, also want to actually take that first step out. Both of you guys are very established in the fields and have plenty of experience in working with all these different types of LMIC and other countries. And I think sometimes I always think that it's very important to encourage others because I don't think we do that enough. We don't really empower enough of our people. There's a lot of difficulties in stepping out of our comfort zone, whether or not we don't know who to actually approach, or we just don't see somebody as a example that can follow. So maybe as a conclusion to this talk, perhaps I can give just 1 or 2 minutes for each of you to really just inspire the rest of the people that's still left on this call. A good 130 over people that's still left on this call. So yeah, please go ahead. Prof, you can take the first.
Thanks. I guess I think in a sense it's harder to get into global space and work in low middle income countries now than say it was when I was starting out, where it was just sort of happens accidentally, whereas now you have to be much more intentional about it. But at the same time, that is good, particularly if you have clinical allied health training. There is always a need. And that is where Dr. Zeena, particularly, you can offer advice on how it is now, because it's changed considerably from when I was working in humanitarian NGOs. However, if you're interested kind of more on the research side, more on the stuff that I'm doing now, it depends a bit on how thick your skin is and your patience to some extent, as we were having a little bit in the chat. It's easy to kind of do small, sort of quick seeming wins, but it's also, those don't tend to last. So there's a huge need for really people with the energy and patience and drive to try and make better decisions, do more interesting, more innovative stuff, whether it's with technologies, whether it's with in interpersonal stuff, to really make some changes, because a lot of these issues that we're looking at now haven't changed since I started out 100,000 years ago. So it's each time we need a new generation to be interested and to get some experience. I mean, I always have volunteers joining, do a little bit of work with us here, go out on some volunteer assignments, get some experience on your CV, and then you look more interesting to the international organizations, to the bigger humanitarian organizations, etc. They like people who've had some sort of experience first. And if you can manage to do some volunteering, that's a good way of getting it. It's the fastest way to get it. If you cannot, then you can just, take a bit more time to move into that space, but it is possible. Oh, yeah.
Maybe I quickly just want to answer Jeanette's question. If she'll be able to work, yes, she will be. So most of the time NGOs look at clinical experience. They don't look at whether you are consultant or specialist or trained GP. They actually look at your experience. So even if you're a very well-trained MO, had a lot of clinical experience, they're very happy to have you on board. Having said that, I just want to highlight that, as someone who has had this dream for a very, very long time, but I keep telling myself, oh, I just got into residency. Oh no, I'm doing my MPH. I finish my MPH first. Oh no, COVID already, I cannot go. Oh no, SR already. SR, a lot of responsibilities. And I decided to just take a step back and say, look, if I keep making excuses, I will never go. And which is why I put my foot down. And when I was turning R5, and I just said, okay, I'm going to take the time off and go. So a lot of the times, if you really feel like you have to do it or you're interested in it, I think you just have to take the step and just step out of your comfort zone. There are actually a lot of opportunities out there. The best way for you to reach out to these organizations is not only Googling them. You can actually go on LinkedIn, and there are a lot of networking that you can do. And these are all informal ways that you can get introduced to NGOs, and then you can just write to them. I actually got to know about MVI from listening to a podcast, and then I realized that actually this one sounds very familiar. Then one of my friends actually did it. So I actually got to know about this NGO through a podcast. So there are a lot of different ways that you can actually come up to know about these NGOs, especially if you don't have the time commitment or the gung-ho attitude that perhaps MSF needs you to have, because MSF commitment is about 9 months to 12 months. And even if you don't know, but you're interested, I think doing this experience is really, really good, because if you go out there and you realize you're a liability or you don't like this kind of work, which some people have come out and they said, hey, actually, I don't like this kind of work. I don't like the uncertainty of it. I don't like working in this kind of settings. And that's fine also. You've learned something about it and now you know. So I would really inspire, I guess, get all of you, empower all of you to do it and take the step. If you're all, I'm very happy to reach. I mean, if you guys want to ask me more or have a chat, I'm very happy to actually talk to you or have a chat.
Thank you very much. A lot of people are sending hearts now, so I think a lot of people will come and find you for chats for sure.
Yeah, no worries.
Okay, so I'm mindful of time. It's 2:10. Thank you very much for everyone being on the call. Thank you very much, Prof. Natasha, Dr. Zeena, for really just taking the time to do the talk. For everyone else, we have reached the end of our series on humanitarian health. The next series, if I'm not mistaken, will start in about 1 to 2 months' time. It will be on health policies, and this will be both locally as well as in the global context. Do scan this QR code. So it's me and the rest of the team that's trying to rack our brains to come up with good topics and invite good speakers, but we really would like to get the feedback from the ground so that we could actually invite more speakers that you guys would be interested in. So do feel free to just scan the QR code and give us your feedback on what we can do better. Meanwhile, once again, I really like to thank Prof. Natasha, Dr. Zeena for your time, and for everybody else here, the 100 participants who are still here. Thank you very much for remaining with us for the last 1 hour and 15 minutes. So once again, thank you very much. Hope to hear from you guys. Thank you, everybody. Bye-bye, everyone.